Now let me have an honor to invite our second speaker. She is ST7 trainee registrar in diabetes and endocrinology at Cambridge University Hospital, National Health Services Foundation Trust in UK. She has academic and clinical interest in reproductive endocrinology, calcium, and parathyroid hormone disorders and thyroid problems in pump systems. Please welcome Dr. Saira Yousaf. Put your hands together to welcome her. And the topic of presentation is the PCOs puzzle, piercing together endocrine, metabolic, and reproductive aspects.
Hello, thank you very much for the kind introduction. And many thanks for inviting me to talk on this topic, polycystic ovarian syndrome, which may not be very interesting for many internists, as we had quite an interesting discussions before, which were quite high level of nephrology and neurology cases. But I think what I want to discuss in this talk today is that just to highlight why we should be aware why PCOS is a problem, and international evidence-based guidelines for assessment and management of PCOS 2023. And we'll discuss about long-term health outcomes, metabolic, endocrine, and reproductive sequels, and any potential new treatments on the blog. Just to set the stage, in 1953, Mr. Leventhal and Stein presented 7 cases of women which had infertility, hirsutism, and they all had consistent finding of bulky polycystic ovaries, and hence they coined the name Stein and Leventhal syndrome, which is now called as polycystic ovarian syndrome. So if we look at the real-world data from 2004 to 2020, I've used this from CPRD, which is the Clinical Research Practice UK data. In that, they took patients with polycystic ovarian syndrome. About 120,000 patients were matched to controls by 1:1 ratio, age, BMI, and primary care practice. And if you look at the graphs, I think just to put it simply, the incidence and prevalence both are rising in terms of diagnosis of polycystic ovarian syndrome. And a sub-analysis of that data showed that the risk is greatest in adolescents, minority ethnicity population, which is mostly South Asians, and low socioeconomic status. So it is a costly problem as well. If we look at the health resource utilization in terms of inpatient, outpatient, and primary care contact of these patients, it is quite a lot. And if you look at the completed data set in 2019, it costed NHS more than £1.2 billion. And in US alone, in 2021, it costed about $8 billion in a year. So it is a costly problem and should be getting more funding to get more treatment-specific, disease-specific treatment options. Patient dissatisfaction is also a problem, and women internationally continue to feel that their condition is not being explained to them properly. They feel that the clinicians lack knowledge or empathy, and they still continue to feel that they are delayed in terms of diagnosis and treatment. So we'll just quickly go through a little bit about pathophysiology of the condition, which looks, I mean, you can look at the diagram, it looks quite complex, isn't it? So it is a heterogeneous condition in which you can see the hyperandrogenism and insulin resistance are the key biochemical hallmarks. There is abnormal gonadotrophin releasing hormone pulsation, which leads to increased luteinizing hormone secretion and relative deficiency of FSH. And LH actually stimulates the ovaries to produce more and more androgens. And then there is insulin resistance, which can occur at the level of muscles, liver, and adipose tissues. The pancreas secretes more insulin, and the liver releases the reduced amount of SHBG, which again leads to increased free testosterone circulating in the body. So it's a heterogeneous mechanism. In terms of diagnostic criteria, the national guidelines, international guidelines from 2023 still recommend using the Rotterdam criteria, which were published in 2003. The caveat here is that we should exclude other etiologies which may mimic the PCOS type symptoms and signs. So before we go towards the Rotterdam criteria, we should ensure that we rule out late onset congenital adrenal hyperplasia by checking 17-hydroxyprogesterone, thyroid function test, prolactinomas by checking raised prolactin levels. And if clinically suspicious, we need to rule out Cushing's syndrome by doing overnight dexamethasone suppression test, 24-hour urinary free cortisol or late salivary cortisols, depending on your local hospital guidelines. In case of functional hypothalamic amenorrhea, these patients usually have low BMI, but they may even have normal BMI. So this should be ruled out by checking the LH and FSH. In this case, they will both be reduced. And if there is an acute onset of hyperandrogenism or worsening of hyperandrogenism in patients, then it is imperative that we rule out ovarian and adrenal androgen secreting tumors rather than making a diagnosis of a polycystic ovarian syndrome. So this is the Rotterdam criteria. So as you can see, 2 out of the 3 following features should be seen in these patients to make a diagnosis. One is the anovulatory cycle, so a detailed history regarding the thelarchy, menarche, and the ovarian cycles, the menstrual cycles should be taken. In terms of androgen axis, both clinical hyperandrogenism and biochemical hyperandrogenism should be looked into and documented. In terms of clinical hyperandrogenism, as we know, we can use different scores, for example, modified Ferriman-Galloway score to look for hirsutism, and we can use Ludwig scales for alopecia, and then obviously we know about acne vulgaris as a part of hyperandrogenin syndrome. For biochemical confirmation, the most common, obviously the main androgen that is circulating in the blood is testosterone. So we need to assess the testosterone levels in the morning time, and we should be aware that these patients are supposed to have low testosterone, so a good assay is required. For example, liquid chromatography mass spectrometry should be used. And then androstenedione and dihydroepiandrosterone can also be used, but we need to be aware that they can, they decrease with the age. So ultrasound, as most of the patients and the clinicians may think that is necessary to make diagnosis of polycystic ovarian, but as per the guidelines, it is not always necessary. If we have ruled out the other mimics and we have above 2 symptoms, then we don't really need to do an ultrasound. However, the follicle number per ovary is used to make a diagnosis of a polycystic syndrome, and 20 follicles per ovary in at least one ovary is diagnostic. We have to be very careful that we don't use ultrasound in adolescents, especially patients who've got a gynecological age of less than equal to 8 years. So, depending on the Rotterdam criteria, there are 4 phenotypes of polycystic ovarian syndrome. In the interest of time, I will not go into detail about this. And then the new kid on the block, relatively new biochemical testing, which is called the anti-Mullerian hormone, produced by pre-antral follicle cells, is also being used these days. But the guidelines suggest that it should not be used as a diagnostic marker. It can be used to look for confirmation of polycystic ovarian morphology, but should not be used as a single diagnostic test. Also, it should not be used in adolescents, and we should be aware that we should have good assays and age-dependent reference ranges and cutoffs to look at the levels. And also, if patients are already on contraceptive pills, then they may affect the levels as well. So treatment. Treatment is largely symptom-directed. First and foremost, I think the most important one is the lifestyle measures, diet, exercise, and I've put a question mark at bariatric surgery because obviously we don't have enough data on this, but I've added this very interesting trial, which is a multi-center open label randomized control trial carried out in Imperial and Coventry, in which they took 80 number of patients and with a BMI of more than 35 and a diagnosis of polycystic ovarian syndrome. And these were randomized to, by 1:1 to sleeve gastrectomy versus behavior interventions, and medical therapy. And if you look, and the primary outcome was number of ovulatory cycles over 52 weeks by checking weekly serum progesterone. And if you look at the bar chart, the one in pink is the surgical group, and you can see there is much improvement in spontaneous ovulatory cycles in patients with who had the bariatric surgery as compared to the medical intervention group. And also the chart on the lowest part shows the improvement in psychosocial factors as well in the patients who had the bariatric surgery. So we know, I think, for quite some time that weight loss can achieve spontaneous ovulatory cycle, but I think this is a good hard data to say if you achieve significant reduction in weight, then the ovulatory, spontaneous ovulation can be achieved. And the second is the pharmacotherapy. So combined oral contraceptive pills remain the first line treatment for patients who struggle with the menstrual irregularity and hyperandrogenism. The guidelines don't recommend any specific preparations, but they do recommend the low-dose ethinyl estradiol treatment, less than 20 milligrams, as there is no evidence that the higher doses are better than these. Obviously, we used to use quite a lot of ceproterone previously, but they're not recommended to be used as a first line, mainly because of the risk factors associated, including venous thromboembolism. What they do is they increase the sex hormone binding globulin, they reduce the gonadotrophin releasing, gonadotrophin-dependent androgen production, normalize menstrual cycles, and protect the endometrium. The second line, not the second line, but the second drug that is commonly used in patients with PCOS is metformin, which is primarily for metabolic features if lifestyle intervention alone has not achieved the resolution. And obviously, we all know as the internal medicine team that it improves insulin sensitivity. The second line drug is the anti-androgens, which can be considered if combined oral contraceptive pills are poorly tolerated or contraindicated, provided that contraception, adequate contraception is guaranteed. In terms of hirsutism, expectation management is really important because the patients come to you and they suspect that if you start on them on treatment, they will see some meaningful outcome fairly quickly, like within weeks. However, it may take even up to 6 months to achieve any improvement in hirsutism. And we should be telling our patients that treatment will never be curative, so that there's, it will improve the adherence to medication as well if they have that, if they understand what the outcome will be and how much time will it take to see any meaningful improvement. In terms of mild hirsutism, cosmetic measures can alone be used, but mostly in moderate to severe hirsutism, dual therapy is required. Pharmacotherapy to reduce androgen secretions, and action and removal of terminal hair already that are present by using laser therapy, IPLs, or the waxing and other treatments. Although they are expensive and obviously can be quite difficult for patients to manage. I will not go into detail about fertility treatments. I will leave that to obstetric teams to sort out. But just a general idea, the first line treatment obviously remains the lifestyle measures. And then if we have optimized the patient then, and still we're not able to achieve the spontaneous ovulation, then letrozole as the first line, followed by gonadotrophins. And with the gonadotrophins, we need to have the regular ultrasound and dose adjustments. And if that doesn't work, then other treatments like IVF or ovarian drilling, etc. So now I come to the point which is most interest to me is that we should be all aware that it is a multi-system order. I think the name is a problem here because the name is actually, technically wrong. It's not polycystic. And it's basically the premature ovarian follicles that are the problem. So these patients have significant comorbidities, including hyperlipidemia, cardiovascular metabolic disorders, insulin resistance, type 2 diabetes, or obstructive sleep apnea. So mainly we need to screen all these patients that come to our clinic with the diagnosis polycystic ovarian syndrome for all these cardiometabolic disease. Squeeze through this, but I think I would like to show this CPRD data again, which shows the Kerr-Mars graph, and which you can see there is a significant association of patient with polycystic ovarian syndrome with angina, myocardial infarction, and requirement for revascularization. So we know that hypertension, insulin resistance is a problem here, but it does lead to significant cardiovascular morbidity. This is the data again for in which 1,000 women with PCOS were matched to 5,000 controls, and it shows significant association of PCOS with type 2 diabetes with a hazard ratio of 1 greater than 1. Again, confirming that this is a condition that we should look in all patients with polycystic ovarian syndrome. Mental health is also something that we should not ignore, because these patients have a very high incidence of mental health problems, including depression, anxiety, and eating disorder. Again, the data here shows 16,000 patients that were assessed versus control. And depression and anxiety was quite clinically significantly prominent in these patients. Eating disorder, although the number of patients were quite low, but there was association with this as well. So just a quick run through to the neurotherapies that are available. I think we all, most of us know about fezolitinib that is being used for vasomotor symptoms in postmenopausal women. It is a neurokinin 3 receptor antagonism. If you look at very quickly at this diagram, which shows that, as we discussed before, increased GnRH pulsatility leads to increased LH. And this is all regulated by the kisspeptin, candy neurons, and the neurokinin receptor, neurokinin B. So if we try and block the neurokinin receptors to reduce the pulsatility, it may improve the symptoms of patients with polycystic ovarian syndrome. So I think this is a potential new drug on the block. It has been approved by FDA to treat menopausal vasomotor symptoms, but I think it is quite promising in terms of treatment of polycystic ovarian syndrome as well. So I think just this is a quick take-home message. Polycystic ovarian syndrome is not only a reproductive problem, it is a multi-system problem, and all the cardiometabolic, reproductive, and mental health issues should be considered when we see these patients. And it has a high economic burden as well, and we need long-term surveillance for these patients in terms of treatment, and novel biomarkers may inform the risk of metabolic disease and classification. Thank you.
Thank you very much, Dr. Saira Yousaf, for such a brilliant presentation.